Great. Thank you for joining. This is the March 1st webinar of Connecticut's SustiNet Healthcare Workforce Task Force. I am Ellen Andrews. I co-chair the task force with Dr. David Henderson. Today we're hearing from Cindy Lord. She is chair and immediate past president of the American Academy of Physician Assistants. Cindy will be sharing her perspective on the role of PAs in Connecticut's healthcare system, current capacity, and future needs. She has spent much of her career working in both family medicine and academia. Cindy began her career in medicine as a medical technologist more than 20 years ago. She received her PA certificate from Yale School of Medicine and her Master's of Health Science from Quinnipiac. Now she is program director of the Quinnipiac University PA program in Hamden, and she is also an associate professor in the Department of Physician Assistant Studies, where she has taught since 1994. Some housekeeping: if you are listening on the phone, remember to input the audio pin that should be visible on your screen if you want to be able to talk and ask questions. If you're listening on a headset directly through your computer, you don't need the audio pin. We will be keeping everyone on mute until all the speakers are finished with their presentations, and we will have some time for questions. To ask a question, you can raise your hand, but to save time and be sure you don't forget them, you can also type your questions into the question pane on your screen at any point during the webinar. The slides and a video of this webinar will be posted online soon on our webinars page at the Connecticut Health Policy Project. And Cindy, you can get started.
Okay, well, good morning, everyone, and Ellen, thank you, and Dave, thank you for inviting me to participate. This whole project is very exciting, and I think PAs will play a key role as partners in trying to improve and expand the health care of the patients of our wonderful state. I'd like to start with the first slide.
Oh, show my screen. Good morning, Ellen. Sorry.
There we go. Okay, well, just to get everyone all on the same page, I'd just like to start with quickly what are PAs. I think at this point, after about 50 years of being around as healthcare providers, most people can actually say they know a PA, have had a PA take care of them. But PAs are one of the 3 licensed medical providers to practice medicine in our country and in our state. Some of the roles PAs do include histories, eliciting histories, performing physical exams, ordering and interpreting laboratory tests, and as well as prescribing medications for patients. PAs, like physicians and nurse practitioners, are critical thinkers to be able to evaluate, assess, diagnose, and treat patients. Next slide. The growth of the PA profession has been rather steady and certainly has increased over the past several years. The Bureau of Labor and Statistics has listed us as one of the top growing professions in the country, with an expected 27% increase in predicted jobs for PAs in this decade. When you look at the first PA class graduating out of Duke University back in 1967 had 3 PAs, and now as 2008 there were about 83,000 PAs eligible to practice in the U.S., and that's up from 26,000 back just in 1996. So we continue to grow. Next slide. Currently, of the 83,000 able to practice, there are 73,000 PAs in clinical practice.
Oh, yeah, I'm sorry.
Close to 1,400 PAs in Connecticut. When you look at the average salary for a PA practicing, it's about $85,000. When you look at the number of patients seen, when we look at all visits to PAs in 2008 alone, close to 300 million, with close to 4 million visits to PAs in Connecticut. As you can see, PAs also prescribe medication, with over 300 million prescriptions written in 2008. Next slide. So how are PAs educated? PAs must, to become a physician assistant, you must attend an accredited PA program. There are currently 148 provisionally or fully accredited programs in the United States. The typical applicant to a PA program has their baccalaureate degree with at least a few years of direct patient care medical experience and significant coursework in the sciences. The average PA program is about 27 months and includes a didactic phase as well as a clinical phase. Next slide, please. Class and lab curriculum include over 400 hours in the basic sciences, including 75 hours or more in pharmacology, and over 580 hours of clinical medicine, everything from behavioral health to anatomy, physiology, clinical medicine, basic sciences, microbiology. Next slide. In addition to the didactic curriculum, PAs also must complete clinical rotations with over 2,000 hours and a great emphasis in primary care. Core rotations for almost all PA programs include family medicine, general surgery, pediatrics, obstetrics and gynecology, emergency medicine, psychiatry, and internal medicine. In addition, students typically do electives in medical subspecialties, surgical subspecialties, as well as additional training in areas like primary care, which include pediatrics and obstetrics and gynecology. Next slide. To practice as a PA in the country and in our state, physician assistants must graduate from an accredited program and then must sit for the national certification exam administered by the National Commission on Certification for PAs. It's only open to graduates of accredited PA programs. Currently in Connecticut, we have two fully accredited PA programs, the Quinnipiac University PA program and the Yale University School of Medicine PA program. There is a third program that is in the process of accreditation, and that is at the University of Bridgeport. They're currently going through their accrediting process and expect to matriculate students in the fall, I believe, of 2010. Once a student or graduate sits for the boards and passes the NCCPA PANCE exam, they become certified and then apply for individual licensure in their state, and obviously licensure will change from state to state. In addition, to maintain certification, PAs must log a minimum of 100 hours of continuing medical education every 2 years, re-register every 2 years, and every 6 years we sit again for our recertification examination. In Connecticut, licensure for PAs includes identifying your supervising physician that we will work with as part of the team, and completing the application process, documenting at least 60 hours of coursework in pharmacology, as well as successful graduation from an accredited program. PAs in Connecticut can practice in any area of medicine and surgery, and essentially can do whatever their supervising physician feels they're qualified to do or is within the realm of the scope of that supervising physician. To practice, PAs must be in at least telecommunication with their supervising physician. There is not a need for a physician to be on site with the PA. Next slide. If we look at the profile of current practicing PAs in Connecticut, we see that there are close to 1,400 PAs, and with a fair number in family medicine, internal medicine, and primary care. When you look at mean visits per patient to each PA per week, we see that PAs average somewhere in the 70 to 80 visits per week, with total visits overall in the state for all areas of medicine and surgery totaling close to 4 million visits in the past year. Next slide. Next slide. So what about the new grads in Connecticut? Well, as I stated, we currently have two programs. I went back just a couple years to show you there's a little bit of variability. When you look, we graduate between Yale and Quinnipiac typically between 80 and 100 students a year. The mean age ranges between 26 to 30 years old, and the gender mix tends to be more females, and that's pretty classic of PA programs currently, about the 75-25 break for female to male. And if you look at national statistics on who goes into higher education, there tend to be more women at this point going on to graduate programs in all areas. When you look at primary care, what PAs from our two programs are entering primary care, we see about close to 20% of the Quinnipiac and maybe up to 55% of Yale for at least '07. Next slide. When you look, I thought it might be a little interesting to see the practice settings compared to national, because Connecticut tends to be a little bit different. Unlike the nation, where a majority of PAs tend to enter private practice clinics, you see that in Connecticut we have a higher number of PAs that enter in work in a hospital setting. That may be because Yale was the only PA program for many, many years. They're one of the first programs in the country, and it was born actually out of the Department of Surgery at the university, and it may be that because of that, PA stayed at the hospital, and then there was kind of the corridor, the 91 corridor from New Haven to the Hartford area with Mount Sinai in those days, currently Hartford Hospital, St. Francis Hospital, St. Raphael and Yale being some of the largest employers of PAs in the state. But PAs are making their way into community health centers as well as physician offices. I think the data is a little bit off, and this data comes from the annual census survey from the American Academy of PAs, in that there are PAs, because I know we have some of our grads working in community health centers. They just may not identify themselves as that and just say they work in a private practice. But the Stanford Clinic, Norwalk, the Hill Health Center, all of those have PAs, Yale and Quinnipiac graduates, as well as grads from other PA programs working there. Next slide, please. In 2008, kind of similar, graduated in that same range, age, maybe a little bit younger, and again, a similar mix of grads going into primary care. Next slide. Mary hadn't, the Yale University program didn't have their '09 data yet because they just graduate in December, so they're still sorting through those numbers. If you look at our recent numbers, we had 44 graduates total. I thought I'd break it down a little bit so you saw who's staying in Connecticut. 24 of those grads remained in Connecticut, and of those numbers, 11% went into primary care in Connecticut. About 24% of our '09 grads went into primary care, so maybe I'm making some headway as a primary care PA, trying to encourage them. And about half of them stayed in Connecticut with a mean salary for those grads that stayed in Connecticut in the areas of primary care, about $70,000. The mean salary for all graduates for the Quinnipiac class of '09 was $80,000. And I mention that only because as we address some of the issues or obstacles for new grads to go into areas like primary care, I think we need to address those kinds of issues. Next slide. That may be it.
Yep, that's it.
Oh, just the references. Okay, so that's it. I guess I'll sum up by saying we are starting to address those workforce issues by putting out an increasing number of PAs each year. Close to 6,000 PAs graduate from the 148 or so PA programs in the country. I spoke to those grads in Connecticut from Yale and Quinnipiac. However, the other 146 programs do have people who live in Connecticut who are attending out-of-state programs and return to Connecticut, as well as PAs who graduate and want to locate to Connecticut. Connecticut has a very healthy and strong PA Practice Act. We work very well with, as part of that physician-led PA team, and I think we will become integral members of our new healthcare system, and at least the system that we're trying to set up in Connecticut. So, any questions?
Well, I have a few.
Sure.
I'm intrigued that you sit for a recertification exam every 6 years. Is that typical of other kinds of provider groups? I didn't know about that.
Not necessarily, although there are more physician groups now that have started to reboard certify again. As our profession was a newer profession, beginning back in the mid-60s, coming out of the Vietnam War with, medics that came back, were informally trained, there was this sense that the need to assure that PAs that were qualified, taking your CERT exam, to practice medicine and then to continue to remain current in their field. The recertification exam is still a generalist exam. PAs are trained in all 148 programs in the generalist model. Some programs have emphasis in areas, for instance, the University of Colorado Child Health Care program has a stronger emphasis in children's health. The Cornell program is a very strong surgical program, but they train generalists as well. Quinnipiac and Yale are very generalist and broad in their training, and that way we have our graduates able to fill any need. When we talk about access to care, obviously primary care is strong, but access is where are the needs. And so one of the beauties of the PA profession has been the flexibility of the profession to be able to fill where needs exist. So it's been long-standing to continue to have PAs recertify every 6 years and maintain that generalist training, that we don't forget that. The NCCPA, the certifying organization, is currently looking at extending that certification process to 10 years. It somewhat matches what physicians are doing, as well as it wouldn't just be take the test, but adding increased requirements dealing with the current competencies of our profession, which are similar to those competencies seen on most credentialing forms: professionalism, medical knowledge, patient care, healthcare systems. I'm sure you're familiar with all of those. So they would be adding more requirements in addition to an examination, but documentation that PAs are fulfilling those obligations as well.
That's great. Oh, sorry, David, go ahead.
Actually, no, I was just going to add that I think all the primary care, as far as physicians are concerned, all the primary care specialties now have recertification requirements. I'm not really sure about a number of the subspecialties. I think that there may be a number of them that are lagging behind, but that I can dig up that information.
Yeah, I mean, I think it's a wonderful thing, and obviously I'd like, my providers to be on top of things. I haven't heard about it as a barrier, and so I'm not going to go looking for them. But another question I had is the level of debt that students are graduating with. I'm not surprised that you make $10,000 less. I'm surprised it's only $10,000 less working in primary care, given what we've heard across the board and in other task forces at the Capitol. Do you have any thoughts around the level of debt that students are graduating with and whether that's a problem? And also, do PAs, if they were working in, and I know I was surprised to see 0 working in community health centers. Do they share, because I know of some, do they share in the loan repayment program if they're working in an underserved area?
Okay, yeah, so let me start with the first one. Level of debt is tending to increase, and that probably has two factors. Number one, school has gotten expensive, and so it's, to go on to graduate school, and all PA programs are at least at the master's level. And we did have a doctoral summit last year. The profession held a doctorate summit and felt that that was not necessary for our level of training, that PAs are competent and provide appropriate care, and that by going to, for our profession, that it wasn't necessary, that it would add debt, it would add increased time, so it would not impact in a positive manner the workforce issue, and ultimately we weren't sure how that would help patient care. So if we go back to debt, because the average age of PAs is now decreasing, back in the 70s, 80s, and even 90s, people didn't grow up saying they wanted to be a PA. They kind of learned about the profession as they were in typically some form of health care: nurses, OTs, PTs, med techs, respiratory therapists, etc., and then went back to school to get their education to become a PA. Today, we see people at both Yale and Quinnipiac who grow up through high school, plan their college career, go into pre-PA programs like pre-med, pre-vet, pre-dent, pre-PA programs in college, and then go right into PA school. So we're seeing an increased debt load because they're bringing debt from their undergraduate education, which most of us, as the old-timers, the first, second, third generation dinosaurs, did not bring, as well as the increasing cost of higher education at this point. That in turn does have some influence on how they choose where they practice. We've surveyed our graduates, we've surveyed our students, and asked them about their like of primary care, again, including family medicine, general internal medicine, peds, even OB-GYN, and they do have interest and excitement. But when you look at salaries, and I'll tell you, the mean salary of the graduates for '09 was $80,000, but the range was, like $70,000 to $115,000. When you look at lifestyle, which is another thing similar to, I think, as med students graduate, look at their lifestyle now, where graduates from PA programs can work 3 12-hour shifts in an ER and make between $90,000 and $115,000 as a starting salary and a new grad, or work in orthopedic surgery and with starting salaries of $85,000 to $95,000. They look at lifestyle. They look at family physicians. They look at PAs in family practice who work 5, 6 days on call. It's part of their life, and they're making lifestyle choices as well. So I think similar to some of the obstacles and barriers that we're seeing for med students entering into family practice, PAs are following the physician colleagues and seeing some of those same barriers.
And in terms of the health shortage areas and loans?
As far as health shortage areas, we do participate in National Health Service Corps has money, certainly has specifically allotted. Physician assistants are included as named groups in National Health Service Corps, and both Yale and Quinnipiac have students each year who enter into the program as National Health Service Corps scholars, or when they graduate from the program. We have a number of graduates who have gone to areas in Connecticut, especially, your healthcare clinics, and are working in those areas and are part of loan repayment. So that continues to expand. I actually sit right now on the committee, the search committee, which is part of the Connecticut Hospital Association, Community Healthcare Association, and they did receive some stimulus funding, and we've developed an application, and we're setting up a process where residents, med students, nursing students, nurse practitioner, and physician assistant students will be offered rotations or opportunities for rotations in these Connecticut healthcare clinics, community clinics, and it would be more than just seeing patients, but doing projects, working on how to improve patient care, and other things to try to encourage them to then take a job in that area. So we're trying to incentivize students with some unique learning opportunities.
Great. Mary Warner has either a question or a comment. Mary, are you there?
Yes. Can you hear me?
Yep.
Okay. So talking about debt, I just wanted to add in, it's true that most of our students come
Mary,
with...
why don't you say where you're from?
Oh, I'm sorry. I'm the dean for the PA program at Yale, and it's true most of our students do come with a large amount of debt, and by that I mean between $30,000 and $50,000, and then generally the average debt for the PA program is between $40,000 and $50,000, and tuition here is $28,000 a year, and it goes over 27 months, so you can imagine the overall cost. And I think that that is a huge barrier to students who are looking at primary care as a career. And I'm hoping that when Washington figures out what they're going to do with healthcare reform, that revising perhaps GME allocations might offset a little bit of that debt. That's one proposal anyway.
Great. Yeah, I wish our task force could tell the feds many things, but unfortunately we don't have that kind of jurisdiction. David, did you want to say something?
Yeah, I have actually sort of a two-part pipeline question. One, from I think it was your fifth slide, Cindy, gave some demographic information about students who enter PA programs having 4 years of clinical experience. It sounds like in your response to one of Ellen's questions that has begun to change, and more students are moving directly from undergraduate programs into PA programs. And I mean, have you started to see trends in their practice choices based on that? Because I certainly know from like medical school admissions that the typical profile of a student who's likely to do primary care is usually an older student who's had some other experience or sometimes even some other career, students who are from underserved areas, and minority students. I mean, I think that profile among medical students tends to identify students who are more likely to choose primary care careers than others. And do you have a good sense of, number one, where your students are coming from demographically, particularly as far as socioeconomic background is concerned, and also how you think you may be able to direct more of your graduates, I shouldn't say direct, how to encourage them to pursue careers in primary care.
Okay, so a lot of questions there. Let's start with the first one, which was, has the average have the number of years of experience decreased? And again, Mary can jump in. Hi, Mary. Mary can jump in too. But I will tell you that, yes, it has decreased. However, in our program, and it's in most PA programs, we still strongly encourage, and we require direct patient care experience and strongly encourage our applicants to have at least a year of direct patient care experience. And I will tell you that too has varied, Dave, because these students come now as patient care techs. They've worked as an EMT through college, so they do come with experience, but it is not the same duration, and they weren't a nurse for 10 years, or they weren't an OT for 5 years. I worked in oncology for 8 years. So those things we see less of, and see some of that has to deal with the cost of higher education. You're going to give up a full-time job and how to support your family, etc. So there's impacts there. But they are bright, and they have the desire to be a PA, so they do well, and they do well clinically, not just academically in the didactic phase. But we haven't yet seen a trend of the typical older student, the one with more experience, necessarily going into primary care more so than the younger ones. We have been tracking that here at Quinnipiac and have not, there's been nothing statistically significant about that. And you can see from our data, and I think Mary can address her data, the data from Yale as well, that every year it's a little different. And I always say, as I'm doing information sessions, I don't know where that class is going till they do their employment survey, and we have close to 100% participation each year from our new grads. They know how important it is for us to have the data. So they do respond, but I really don't know till all the dust has settled where they're actually going to end up. When we do know the demographics of our applicants, as well as the demographics of the students who come to the program, and we are working to try and increase our applicant pool as well as our yield from acceptances from those students from underserved and underrepresented communities. Quinnipiac never had scholarship, being a private, small private school, you can imagine. But in the past 2 years, this is the third year, they've given me 7 partial scholarships, and that has helped to bring students from underrepresented communities to the program and help them get through the program. So I think that is going to be important about scholarship and incentives, as well as, I'm hoping that similar to National Health Service Corps, there'll be incentives similarly for our preceptors. When you look at family practice docs, NPs and PAs who are taking students, they too need some kind of incentive because it is, as you know, Dave, it is a full-time job to precept students. And we have students in the practice I'm at. You still have to see the same number of patients and get all your work done. So I think we need incentives there, as well as what we're talking about, as I mentioned, with the search committee, part of the Connecticut community healthcare system, working on ways to get training so more PA students are actively in things like community health clinics, and seeing the good work they can do and providing them not just patient care experience, but outcomes and ways to actually enhance and change the practice, how the medicine is practiced in that healthcare system. Those are going to be important ways to entice people to get into primary care. Mary can comment.
Yeah, so I'll just add a few things. One is that it appears about 24% of students currently are minorities, and that includes all minority groups. And one of the things that we've been focused on really for the last several years, and it was as a result of a HRSA grant that obviously was not reauthorized, or not obvious, but I can tell you it wasn't. And in that case, we decided to focus very heavily on trying to get underrepresented minorities and those from socioeconomic backgrounds that are quite varied into our program, and spent a lot of money on recruiting in different locations all over the country. And it yielded for us a marked improvement in the number of individuals coming from Southeast Asia, Thailand, Vietnam, those areas, as well as others from China and things like that. But it really did not improve at all the recruiting that we've done at historically black colleges to try to improve our even really our applications from underrepresented minorities who classify themselves as African American. And so and we've spent several years on it. I thought maybe it would take a little while to see the lag, and in our case we have generally 10 to 15 people who apply who identify themselves as African American. But I think that one of the reasons that happens is that, and I've heard this from several people, Yale has a large Robert Wood Johnson Foundation summer program for individuals interested in any kind of health care, and it's underrepresented either socioeconomically or from an ethnic background. And what we've seen is that when we've talked to those individuals, everyone was interested in the PA profession, but they were all being counseled by their colleges to apply to medical school, and I think most of them end up going to medical school rather than to PA school. And so that's an area that we've been working on, and we haven't really made a lot of headway. And the other thing that you should know is we have a centralized application service, and the data, they just added a question about, and it's self-report of course, but are you economically disadvantaged? And the data about the economic disadvantage and tying that really to what people end up doing as they graduate hasn't been done. And really even the percentages of individuals applying to PA programs who are economically disadvantaged has not been reported either. So we've gone through several iterations of the application, and I think we're at the point now where we probably can report something. But what I can tell you is that if you look at the difference in the both the debt load as well as the scholarship, if you use scholarship, because at Yale we have a need-based scholarship program. So if you use need as reference to find out where these individuals are coming from, I can give you a very simple example. About 2 years ago, the medical school, I think this is when we had different endowment payouts, as you probably can imagine, they decided that all students who came from families that made less than $100,000 a year would be eligible for scholarship. That would be our new need criteria, and they publicized this. And we looked at applying that. So we applied it to the medical students, and as you might imagine, it didn't impact the bottom line payout for scholarships that much, because there are lots of students who come to Yale whose families make more than $100,000 a year. So we looked at applying the same rule to PA students, and it was going to more than triple the amount of financial aid that we would give out. So our students definitely, when you compare them to medical students, come from backgrounds that are certainly not wealthy by any means, and I'm not saying $100,000 is wealthy. I'm just giving you sort of an example. But most of the students actually would have applied or would have been eligible for financial aid, and of course the dean's office went crazy when they heard about this. So we decided not to apply it to the PA students because we really couldn't afford to do so.
Interesting. This actually is another sort of pipeline-related question. I mean, we've had presentations by a number of different folks from various professions, and particularly in nursing, there's an issue with faculty recruitment. Are there any similar such issues among PA programs with finding enough faculty, particularly clinical faculty, to sort of teach in the program itself, and also practice-based sites to provide some of the clinical experience your students need?
Mary and I could probably sing the same yes song.
Yes.
And you know, it's not necessarily because of a desire, but also when you look at salaries and what practicing PAs, clinically practicing PAs are now making, the disparity between that and what educators make is becoming significant. As well as, again, I'll say lifestyle choice. I can turn my beeper off at night on my clinical day and go home. Here, as an educator, you can't turn that off. So finding full-time faculty continues to be a challenge. Clinical faculty, a similar challenge, especially in areas like pediatrics, obstetrics and gynecology. We all talk about the same thing, pediatrics, finding good quality sites. And certainly as requirements for productivity have increased in practices as well as hospitals, that's added more burden to it. So the answer is, yes. And you try to work around that and provide ways that they can have students and continue productivity, but it definitely has an impact. Mary?
Well, I just add that a few years ago, probably 2 or 3 years ago, so you should know that the number of PA programs has really dramatically increased since Cindy and I graduated, and I think it's ironic that we both graduated in the same year in '91, and there were 54 programs. There are now 148 programs, so even getting faculty at the programs at the universities that are housing them is an issue. And a survey from a few years ago suggested that the turnover of program directors was about 20% in 1 year. It's down to 15% now, but there's a lack of leadership at the highest level, as well as lack of general faculty to fill the slots. And I'm not sure, but I would expect that both Cindy and I have been very lucky, not lucky, but I think very fortunate to have access to great faculty. So when we have openings, generally we've had, I would say, a plethora of individuals who've come forward interested in participating in PA education on a more full-time basis. The problem, though, is that there are lots of programs around the country that don't have that, and if you search the job searches, some of them are open for over a year looking for faculty members. So there's a problem really getting enough faculty, core faculty at the PA level or at the program level, as well as leadership So there are many program directors that are very new, and that estimate that I just last heard was about 20% of program directors have been in the position less than a year, and that's a huge percentage. And I'm not saying that you didn't come with experience or whatever, and in my case I had a lot of experience in PA education before I became a program director, but there are a lot of individuals coming right from clinical practice who had administration and management positions and have moved into program director positions and really aren't familiar with some of the things related to education quite in the way they need to be, such as accreditation and so on. And our accrediting body is looking at that very carefully. But I think that if you asked around, and my dean asked me recently, you know, would you like to increase the number of students that you can take in the program, and we noticed that your class is 36 students generally to 38, and you have in your classroom 50 seats, so wouldn't you like to increase? And I said, well, of course, if I can get additional clinical sites. And when we look at the distribution of clinical sites for PA students and medical students, because we rotate using the same clinical sites that the medical students use, there really aren't enough sites. And there's just, at this point, trying to recruit additional individuals with the cost pressures and reimbursement issues, that's a huge barrier to increasing the number of students that we have.
Can I ask a question?
And that question,
I'm sorry.
oh, sorry, Ellen, that question gets posed to me on a regular basis here, and I respond the same as Mary. It's really, and it is rate driven, I think, by the number of quality clinical sites, but Mary will probably agree with me in that it's, you don't just put another seat in a classroom.
Right.
When you look at all the need for small group learning, the number of students per cadaver in anatomy, the number of students in a surgical skills lab, or anything that has competencies associated with it where you have to sit one-on-one and check off and make sure that they're competent in that area. The other thing I would add, that PAEA, which is the Physician Assistant Education Association, another one of the 4 major organizations in our profession, and Mary spoke to some of their data. There's also a high turnover rate in certain areas of PA educators, specifically clinical coordinators. Mary, I think the last data showed that there was about 3 years, I think. The average clinical coordinator at a program lasts about 3 years. And as you can expect, it is kind of a life of turmoil with what site can't take someone this time when they said they could because somebody's out on maternity leave, or they're down short people, or they just need a rest. There's this kind of level of uncertainty that every clinical coordinator lives with. But then on top of that, I think there are increasing burdens with being able to get students into rotations. And so that adds another variable of kind of the turnover rate in that specific area of PA education.
I wanted to ask, I mean, this is something that comes up across, not surprisingly. I'm actually really excited to hear that in terms of the Connecticut programs, at least, attracting faculty hasn't been a big issue for you. I'm glad to hear it, and let's, knock on wood somewhere. But in terms of increasing the number of clinical sites, I have heard, from legislators and others who are maybe a little further away from this, well, we give all those hospitals a lot of money, we give all those clinics a lot of money, we'll just make them. Yeah, I know. Right. They don't have enough nurses, they don't have enough PAs, they don't have enough physicians, and you're going to make them do something else. That's probably not, the best way to handle it. Do you have any ideas of things that the state government could do, or in a bully pulpit, to help encourage that in the future? When you hear from clinical sites, what do you think we could recommend that would help them? Not all at once.
Yeah. So I think that I'll jump in, Cindy, if you don't mind.
Go ahead.
I think training stipends for primary care sites, which it sounds like that might be in the works, or that's what I seem to understand, from the conversation earlier. I think there's a lot of discussion about changing the way that GME is authorized, and one of the discussions sort of on the Hill at this point is to look at not distributing it to hospitals, which would really encourage specialization right off the bat, but to try to divvy up the the money so that part of it would go to a hospital and part of it might go to an outpatient clinic and or to a primary care training program. I don't think that I've seen or heard anything that is solid yet, but that might be one way that our state could improve access to primary care. Is the notion that reorganizing really the way that GME funding is provided. And currently, there really is very little money available, and we know with ERA, the Recovery Act, that there was supposed to be a certain amount of money set aside for HRSA training in primary care and dentistry, and it ends up that there is some money available now, but it's really not available to us, and when you parse it out.
Actually,
Yes?
Mary, let me interrupt you. In the guidance that was issued by HRSA last Wednesday, I think there is, $48 million available through RRA funding, with the plan of funding about 100 grants.
Okay.
I can send you that guidance if you don't have access to it.
Actually, I just was looking at an email from my colleague, and it says the same thing. You're right, but I think a lot of that is, what they do is they earmark a lot of it for undergraduate medical education and residency training, and there will be some available for PAs, but it won't be as much as probably is needed, especially to help early. I'd love to get the funding, but the fact is that we are doing fine without the funding. I probably shouldn't say that publicly, but
Yeah, this is being recorded,
well, let me actually no. I have to redact that statement. But I think there are some training programs, especially newer programs, that could really, if they had adequate funding, they would be able to attract faculty members easier, and they probably would have better luck finding rotation sites. But I think what I'm hearing from a lot of primary care practices is that they're looking for some support from the university and from the program to help them continue to train students. And it seems to be a more popular notion than before, because there are some PA programs who are paying for sites. And that's very controversial, and I'm not suggesting that I'm supportive of it. On the other hand, if there were some specific training elements that the sites were providing to our students, this would be a great opportunity to help fund them through HRSA or a reorganized GME funding.
Great.
Cindy?
Well,
I would add that I agree with Mary. I think she's kind of summed it up. But I would also add that I think in the training piece, and again, PAs have always dealt with not the specific carve-out. We're kind of lumped in there. So there's little bits of money. And when you look at making primary care training a little bit different, adding a little bit more experience to it than just seeing patients. I mean, as an educator, I watch these students, and it's almost like you have to be entertaining. But it's rigorous work to be in primary care. There's a lot of, we need to make it more glamorous, unfortunately. There's just not a choice. And to do that, I think the exposure as a student when they rotate through has to include more than just seeing patients. So, interfacing with the community and planning of community projects that look at things like health promotion and disease prevention. I mean, as a nation, we need to, as healthcare providers, we need to make that more glamorous, because no one seems to find that very exciting. It's more exciting to put in a chest tube, put on a cast, harvest a vein, or put in a stent, a drug-eluting stent, and there is excitement. As a primary care PA, I will tell you there is excitement in primary care, but I don't think we've capitalized on that. So I think the actual curriculum in primary care has to change a little bit. I think it's way out of date. And I think, students need to be able to be exposed to that, looking at healthcare disparities projects, etc. So I think we need a little bit of that as well as just a stimulus for money. And both Yale and Quinnipiac do deal with a number of PA programs that come into the state that pay. Neither of us pay. We all work on the see one, do one, teach one. It's our obligation model. But that we face those challenges not only from some of these other PA programs that come in from other states, but as well as offshore medical schools that are sending their individuals up here to train. And that's another force. You know, when life was good and there was a lot of money around, it never seemed to matter as much. But now that hospitals are struggling and we've seen hospitals go out of business, we get asked all the time to pay, and we continue to say no and try to continue to encourage them about our obligations as healthcare providers. But so I think we need to look at our curriculum as well.
Well, I know legislators will like that because it doesn't cost money. That's good. Well, that's great. I don't see any other questions. David, I don't know if you had anything else you wanted to add?
I'm good, thank you.
Okay. Well, thank you
This has
both
been
very much. Yeah. And this will be up on our website as soon as I get around to posting it. Thank you all very much.
Thank you.
Well, thank you for allowing us to participate.
Great.
Bye-bye.
Bye-bye.
Bye-bye.